Yes, so good morning, all. It's a wonderful day, and we take up a wonderful topic on this day. I think the hall is going to fill up as the day advances. So, the wonderful topic is CE, that is cluster endophthalmitis, a topic that all want to know of, but no one want to talk on, or only few want to talk on. So, we have with us an experienced team in the IC experienced speakers. I welcome my co-instructors. We start the IC with keynote address of Dr. N. Narendran Muthu Krishnan. Dr. Narendran is a practicing VR surgery at Manipal Hospital, Malaysia. He did his MBBS from Kasturba Medical College, Manipal, obtained his ophthalmology specialization from the Royal College of Glasgow, and did retinal fellowship from Sankara Nethralaya, Chennai. So you can take the dais, sir. He'll be giving a note on prevention and management of endophthalmitis. Dr. M. Narendran's talk.
Good morning. I'd like to thank the organizing committee for giving me this opportunity to talk. And Dr. Rodney, I apologize. We're going to be overlapping with our topics, but I'll try to keep it very basic so that it makes things easier. I think the wrong presentation.
Dr. Narendran talk. You have loaded, sir?
Yeah, it's loaded. So basically, endophthalmitis is something that we don't want to deal with, but unfortunately, it's a reality when we do enough surgeries that we are going to end up with having a very virulent infection that's going on to go in the eye. There are multiple causes for these infections. Of course, we know one is exogenous and endogenous. Exogenous most commonly is post-operative, followed by traumatic. And of course, you have your acute onset, then you have your cataract surgeries, you have multiple ophthalmic surgeries that can lead to these things. Okay. The percentage of incidence is about 0.03 to 0.7 for cataract surgery. For glaucoma is 0.2 to 1.5. And post-vitrectomy is about 0.05. And intravitreal injections, which we are doing, the numbers are high. Of course, the percentage respectively likewise follows through. Prevention is the most important thing. So we have to look for the risk factors. So if you have patients with blepharitis or eyelid pathologies, and of course, systemic disease, most commonly diabetes, and of course, advanced age where the immune system is a little bit compromised, the risk for endophthalmitis is much higher. And also the intraoperative risk factors like posterior capsule rupture, vitreous loss, and the hands of inexperienced surgeons. I don't mean to be this thing, but then when you have trainees, of course, you have the higher incidence of these things happening. The other source of infection, of course, is from your theaters, where Hepa filters is extremely important. Okay, and then your medications, your solutions that you use, try not to reuse or make it a single use, and of course cleaning of your periocular tissues, irrigation with povidone, and your surgical masks. If they are soiled, sometimes we do tend to have not feel a bit under the weather. We might be coughing and might be using the same mask for reasons. So always good to change your mask if you feel soiled, and having sterile instruments. So prophylactic, what you do is treat the local factors, optimize the systemic conditions. Diabetes is, my target for this thing is I tried anything 10 millimoles and above, I try to avoid doing surgery. Cataract surgery, there's no urgency for the surgery. It can be done at a later stage. Of course, 10 is something that I follow, but each individual, if they have a good control, you can, and have a good internist with you to help you, you can manage them. And preoperative topical antibiotics, I'm not a great fan of that because I don't think so really helps preoperative antibiotics. Airflow design for your theaters is very important, having negative airflow. And then your equipment sterilization and single use of instruments is very important. Now, povidone iodine studies have shown that irrigating the cul-de-sac with 5% povidone and the periocular surface with 10% povidone, it really helps with the incidence, lower the incidence of endophthalmitis. So my policy is I always drop 5% povidone to the cul-de-sac, and then I do the periorbital cleaning, and I leave the povidone there for 3 minutes. It shows 3 to 5 minutes is good enough. So I keep it there for 3 minutes, and then I wipe off the thing. And having a sterile, many places they are using drapes, cloth drapes, which do not have a very sterile environment around the eye. I prefer to use sterile adhesive drapes where you can really isolate the eye from the surrounding areas. And having a good corneal architecture for the wound, self-sealing wounds. And if you do have any doubts about your wounds post-surgical, we always tell our patients we are going to do sutureless surgery. but I think we really need to look at what we are hoping to achieve. If you feel you suspect the wound or there is some form of a micro leak that you are suspecting, putting in a suture is not a big thing. We can always remove after 5 days. A few times I've actually on table, examining the patient about 2 hours after the surgery, I have noticed a micro leak. The choice is between putting a bandage contact lens or taking in to theatre. Of course, the easy way out is a bandage contact lens, but then at the same time, you're not very sure how effective that is. So I always explain to the patient, and I take back to the theatre and put a single suture because it gives you a good night's sleep. At least you have a tight wound. And of course, intracameral antibiotics is extremely important. Okay. Most important is counseling of patients post-operatively. I think that is something that is very important about hand hygiene, installation of drops, teaching the family members, because most of the patients are elderly who have difficulty of holding onto the bottle and trying to drop the eye medication into the eye. So I counsel the patients, I counsel the family members. I actually give them a 3-page instruction, pre and post-operative. It's like an essay. I get them to read. Since I'm coming from a multinational country, so I have it in various languages, Malay, English, Tamil, and Mandarin, so that it's easy something for them to understand and comprehend and to follow. And we give them details about their lifestyle they have to maintain and all that. So the thing is, with Asians, cooking seems to be a very important thing. Doctor, can I cook for my family? So I tell them, yes, you can cook, but you get somebody to cut the chilies and the spices and all that. Chilies, onions and all that, because they want to cook. I allow them to cook, but get the cutting of these all these pungent materials be done by some family members, and they can just do the cooking per se. And clean eye toilet, I tell them to clean the eyes, because I've seen patients coming back for follow-up with the drops dried up on their lashes, and that is a source for possible infection to set in. So I teach them, you boil water, then put cotton balls in this boiling water, let it cool down, and then take out the cotton and gently clean the eyes. So that helps to loosen up these hardened medication particles, which can be easily removed. And most important, when they do present to us, when it's our own case, sometimes it's difficult for us to accept there is an ongoing infection in the eye. When it's a referral case, it's very easy for us to make that diagnosis. But patients will present with blurred vision, red eye, pain, lid edema, and 75%, most of them within first 5 days to 7 days following surgery. So they'll have corneal edema, AC flare, hypopyon, vitritis, scattered retinal hemorrhages, periphlebitis, loss of red reflex, and capsular plaques. Of course, there are other differentials that you have to think about. Toxic anterior segment syndrome, exacerbation of pre-existing uveitis that could have been missed out, or retained lens matter, usually subincisional, sometimes gets left out if the pupil becomes myose intraoperatively and you just are done with the surgery and you miss out a cortical matter. We have to check on all these things. Okay, so when you do get these patients, history taking is very important. If it's your own case, it's okay, but when you're getting a referral, I think history taking is very important regarding the systemic condition of the patient, whether they're aware of what was any problems during the surgery, whether it's a prolonged surgery. And of course, you go call back the doctor who has referred the patient to you to find out anything that they could help you with. And working up these patients, sometimes we have patients we have seen who are turned to a newly diagnosed diabetic. When you do a dextrose stick, the sugar is about 22, 23, and the patient has no prior knowledge of having diabetes. So that is another thing. You still have to work up the patient as a new patient to work out to see whether they have diabetes, because it could be an undiagnosed diabetic that could be causing this. And of course, an anterior chamber tap and a vitreous tap has to be done, and intravitreal antibiotics. Microbiology, we use the standard methods for the culture plates. Okay, and of course, polymerase chain reaction does help us a lot to make things more positive. And most organisms, as you see, are staph, staphylococcus, streptococcus, and gram-negative organisms. Okay, the antibiotic regime is quite standard. The role of steroids. It does help us with the inflammatory aspect of these infections, of course, but then you need to make sure your gram stain has and your KOHM has no microbiological organisms or fungi, and they do help. And of course, EVS study says that used to say that you do these surgeries for patients who have only vision with PL or worse, but then when you look at it, The early vitrectomy study says that you go in as early as possible to do a complete debulking and to help minimize your tissue damage. So I'll just go through these. Okay. So the end results say that early vitrectomy does help. So this is the algorithm that normally we follow. And I'd just like to highlight a case. This was a teacher, headmistress of a school, who was referred to me by my colleague 1 week post-op. This was the presentation. Her vision was hand movement. And the fundus finding was very hazy view, and B-scan was showing this kind of low refractive opacities. She refused surgery. And of course, you need a consent for the surgery. So I always have an endophthalmitis kit in my clinic. So it's all ready, pre-prepared and everything. So my target is the moment the patient presents, the moment make the diagnosis, within an hour I try to do the tap and the injection. So following the injection, we gave the vision as hand movement, and 2 days later the vision improved to 660, and the gram stain and the GH came back as no organisms. So I was a bit encouraged, so I decided I'll give DEXA along with the intravitreal. I gave the DEXA. 3 days later the vision improved to 6.9. Of course, this is one of those things where I think, and the teacher said, see, I told you, I'm a teacher. I know what works for me. Okay, I mean, not all cases needs to be operated upon, but it's very rare to get these kind of things to have a good outcome. So, like I said, this was a race. I didn't win, but the fact that I didn't fall and break my bones was enough victory for me. So, likewise, in our management for endophthalmitis, we might not be able to save the eye in terms of vision, but if we can stay anatomically, if we can save the eye, I think that goes a long way in the psychological profiling for the patient. Thank you very much.
Thank you, Dr. Narendran, for that keynote, interesting keynote. I would request Dr. Narendran to join us here so that we can reap further from his experience. So basically, endophthalmitis is not an end for the eye, the surgeon, or the hospital. It is just one of the post-surgery complications, and we should take it as such. Dr. Rodney Morris is our next speaker, senior VR consultant at High Volume Center of Arvind Eye Hospital, Coimbatore. He has seen endophthalmitis front and back, literally and practically, so let's hear it out from him. I shall also request my co-instructors to join me out here. Dr. Revti Madam, Dr. Anand Sir, and Dr. Kalpana Madam will be here in maybe 10 minutes. She has a talk in another hall. Dr. Rodney.
Good morning, everyone, and thank you, Dr. Lippi and the scientific committee for inviting us over for this IC. So I'll briefly go about the on the cluster endophthalmitis alone. So cluster is defined as occurrence of endophthalmitis much higher than the local incidence pattern, or an occurrence of 2 or more cases of infection at a time, or the occurrence of repeated postoperative infections under similar circumstances, either with the same surgeon, same staff, or the same operating room. So this is the broad classification of endophthalmitis. You can have acute, subacute, or chronic, depending on the days of duration, and the organism differs for each type of presentation. So coming to the potential sources for a cluster, you can have it from either the surgical intraocular instruments, or from the irrigating fluids, dyes, and viscoelastics, surgical environment, or contaminated phaco machines. The causative organism for cluster endophthalmitis is mainly the gram-negative group of organisms, and of these gram-negative, Pseudomonas is the most common. These are the varied presentations that one can expect in a case of gram-negative endophthalmitis, where you can it can range from corneal ring infiltrate to melting of the cornea. This is the case of nocardia with nodular exudates within the anterior chamber and tunnel infiltrates. You can get blood-tinged hypopyon or regular hypopyon with dense exudation in the vitreous cavity. And this is a type of chronic endophthalmitis which is caused by P. acnes endophthalmitis. So coming to Pseudomonas aeruginosa, the endophthalmitis, the presentation itself is very aggressive, and you will get corneal infiltrate. The cornea is affected directly from the early days of infection. And when you do an ultrasound, there will be a T sign in some cases of gross infection. There will be gross thickening of the retina-choroidal complex, and there will be a lot of exudation within the vitreous cavity. And there will be CDs also, depending on the aggressiveness of the organism. So Pseudomonas is the most commonly encountered organism in cases of cluster endophthalmitis. We had a series recently of cluster endoff from another external source, and the patients were referred to our center for the management, and you can see there are 5 patients over here, all having a different source of presentation. And some of these patients, 2 of these patients underwent therapeutic keratoplasty to save the eye. And why we said it's endophthalmitis because of acanthaema, because of confocal microscopy. When you do it, you can see that the deeper layers had more of cysts than the anterior layers of the cornea. So the infection had to come from an inside source. You can also expect cases of fungal endophthalmitis in cluster, though rare, and the presentation will be a vitreous haze, and there will be cotton ball opacities within the vitreous cavity, as seen over here. These are the different reported clusters from India. Right from 2003 onwards, it's there. And most of the organisms, if you see in clusters reported from India, are from the gram-negative. And of the gram-negative, you have the Pseudomonas in more common organism. There are 3 alerts that one has to be aware in case of cluster. One is the green, then you have the amber and the red. So the green alert is when one case of endophthalmitis is noted. If there is 1 case in 75 cases, then it's amber. And the worst one is the red one, where you have 2 cases in less than or equal to 200 cases, or 3 in 600, or 4 in 800 cases. So there are some checklists to be followed. So first you have to look into your central sterile supply department. Next is the operating room assistant and the nurse related issues. Then the surgeon related issues and the operating room administration and environment. Coming to the management, you have to follow a protocol for the management in clusters. First is the prompt and effective treatment. Second is to report to the concerned authorities, analyze and cause the identification of the problem, implementation of practices to prevent future outbreaks, and a continuous audit is necessary of complications, procedures, and the practice patterns. So coming to the treatment options, you can have 2 approaches. You can have either consider every post-operative unusual inflammation as infective, or the second approach is where you consider all the indeterminate cases as inflammatory and non-infective. And also always keep in mind the problem of TAS. So something over here. Yeah. So TAS is always you have to keep in mind when you think of endophthalmitis, and you can have the presentation within the first 12 to 24 hours, and clinically you can see the entire cornea, limbus to limbus affected with gross edema, and the signs in the vitreous cavity, it will be a clear vitreous cavity without any signs of any inflammation or infection over there. And the treatment is close monitoring of the patient along with the intensive corticosteroid therapy. So the first approach of considering all the postoperative unusual inflammation as infective. The problem, the downside to this therapy is for every infective case that you are receiving appropriate treatment, 9 out of 10 cases would require unnecessary treatment. And along with that, you have the potential risks of drug toxicity, detachments, false positivity, and the burden on mental, economical, and infrastructural load. If you are considering all the indeterminate cases as inflammatory, you have to have 4 levels or steps. First is to consider all the factors resulting in the inflammatory response. Then you have the investigations, clinical evaluation, and the final protocol. So considering the factors that result in the inflammatory response, you have the 3: preoperative, intraoperative, and postoperative causes that can lead to an inflammatory response in the eye. So that you have to look into it. Investigation, the prime investigation is mainly ultrasound. So you try to do an ultrasound and look at the retinochoroidal complex for thickening, the scleral thickening, as well as the intensity of the exudation in the vitreous cavity. Evaluation of signs and symptoms has already been detailed by Dr. Narendran. You can have the common encountered symptoms for endophthalmitis like pain, nausea, vomiting, adnexal edema, etc. And there might be some overlap with other inflammatory conditions. And the final protocol is to document all the positive and negative findings. You admit the patient and explain the condition to the relatives. You start the patient on half-hourly steroids, dilating drops, topical antibiotics, plus or minus intramuscular dexamethasone. Monitor the IOP and start the anti-glaucoma medications if the IOP is high. Reevaluate the patient in about 4 to 6 hours. And if the condition is improving, then you continue the same line of treatment, or if it's getting worsened, then you think of doing a surgery, core vitrectomy. So this is how you do a AC tap and a vitreous tap. So AC tap is usually done with a 26 gauge needle. You aspirate around 0.1 to 0.2 ml of the aqueous. And after that, you take another needle, 24 gauge needle, and enter the vitreous cavity 3.5 millimeters from the limbus, and aspirate from the vitreous cavity the vitreous fluid. The culture media can be a chocolate agar, blood agar, subrods dextrose for fungi, and thioglocolate for the propionibacterium and other anaerobic organisms. Coming to the drugs that are most commonly needed to be given in a case of cluster is the ones that have been marked. So commonly we give the broad coverage. You give Vanco and ceftazidime. So ceftazidime, the dosage is 2.25 milligram in 0.1 ml. And in some situations where you encounter some resistant organisms, you can give imipenem and moxifloxacin. So moxifloxacin is around 0.2 milligram, and imipenem is 0.2 milligram again in 0.1 ml. Alternative therapies in a case of cluster to be kept in mind is piperacillin tazobactam combination. You can give 225 microgram in 0.1 ml. Carbamazepine is 2000 microgram in 0.1 ml. Ticarcillin clavulanate 3000 microgram in 0.1 ml, and colistin in 0.08 milligram in 0.1 ml. The fungal antifungals commonly used are the amphotericin and the voriconazole. Amphotericin is given in a dose of 0.05 milligram in 0.1 ml, and voriconazole in 0.1 milligram in 0.1 ml. The role of steroids. So when do you inject? So you can inject in all bacterial endophthalmitis when the causative organism is identified and the antibacterial sensitivity is performed. It can be given either after the antibiotics or along with the antibiotics. When not to inject is like already highlighted in a case of fungus, proven fungus, atypical mycobacteria or nocardia. The value of giving steroids, it helps in a faster recovery, helps in the structural integrity maintenance, reduces the fibrinous reactions, and improves the therapeutic levels of the antibiotics in the vitreous cavity. This is the endophthalmitis kit that is available in India now. So should the intravitreal antibiotics be given by the referring surgeon? The answer will be yes, definitely it has to be given by the referring surgeon, especially if the patient is going to be delayed in reaching the vitreoretinal center. Rapidly progressing or evolving fulminant endophthalmitis. If the surgeon is skilled in giving an intravitreal antibiotic, definitely one has to give it. And if the OR, wherever you are referring the patient, if the OR facilities are going to get delayed, you definitely have to give an antibiotic before referring the patient. So the surgical protocol is again, once the clinical evaluation and ultrasound is done, AC tap and vitreous tap has to be done, and intravitreal injection needs to be given. And after the first 24 to 36 hours, if there is no worsening, you can continue the same line of treatment and repeat the injection. If there is no improvement, or if the presentation itself is quite aggressive and bad, you directly go in for a vitrectomy and with intravitreal antibiotics, and you continue the treatment. And if it's improving, you continue the medical treatment, but if it's getting worsened, then you do a repeat full vitrectomy with silicone oil injection. Pars plana vitrectomy, it is improved over the ages, and now with better instrumentation, you can even do a full vitrectomy and even induce posterior vitreous detachment and silicone oil injection, which helps in faster recovery in endophthalmitis, the severe varieties. The relevance of EVS in current day practice is outdated. So with better instrumentation and better antibiotics available nowadays, we can do an early intervention by way of surgery in cases of aggressive endophthalmitis, especially when you're dealing with a cluster. You can go in earlier with a core vitrectomy and intravitreal antibiotics and silicone oil injection if required. So this is, in case there are fibrin membrane that is precluding your view for the vitreous cavity, you can always remove it, as shown over here with the Simcoe. or in certain situations, sometimes the cornea itself is quite bad and you need to do a core vitrectomy. You can always combine the core vitrectomy with the keratoprosthesis. So as shown over here, you can mark out the area of opacity, and then you can do fix a keratoprosthesis. Keep the keratoprosthesis in place, and then it helps in doing a good vitrectomy, core vitrectomy, and helps in a faster resolution. And once the procedure is done, you can go in for a transplant. So as I said, ideally with current instrumentation and antibiotics, always better to do a complete vitrectomy to reduce the infection faster. It helps to reduce the risk of delayed detachments, and PVD induction can lead to retinal tear formation. But with the present day instrumentation, and only to be avoided in a very necrotic retina or in severe aggressive infections, the PVD induction need to be avoided. But in all other cases, it can be done. So this is a video where PVD induction is being shown in a case of core vitrectomy. So you can see the dense exudation in the vitreous cavity, and once that is cleared from the anterior part, you can go into the cavity. And you can do the peripheral exudates, cutting of the peripheral exudates, and once that is done, you can see the exudates on the retina also over here. And once the periphery has been cut, then you can start inducing the PVD as been shown over here. So in certain situations, you can see the extent of damage to the retina and then decide whether the PVD needs to be induced or not. And once PVD is induced, then the entirety of the exudation can be removed from the vitreous cavity. Silicone oil injection, again, is quite beneficial. There are reports in literature, and beneficial role in inhibiting the microbial proliferation in the vitreous cavity has been shown. The tamponade preferred, especially if the organism is multi-drug resistant or fungal, and it can act as a supplement along with the intravitreal antibiotics. IOL removal in certain situations is required. So the indications are in a low-grade infection, which is contained to the bag, in fungal infections as a primary or only at recurrence, a very fulminant gram-negative endophthalmitis at presentation, or in unusual fastidious organisms are encountered. Repeat vitrectomy has to be thought of in about 36 to 60 hours. And the response, the anatomical outcome in literature has been poor for cluster endophthalmitis, primarily because these are all gram-negative organisms. And at the most, after all these struggle, we get about 50% of patients with an outcome of 2400 or better. So in conclusion, tracking an endophthalmitis, cluster endophthalmitis as laid down by the Royal College, you alert your colleagues and make them aware of cases thus far, and recall patients operated on same day or same operating room. Inquire about the incidence of any other case and ensure patients are fully aware of the post-operative danger symptoms. Proper documentation is quite required and mandatory. If receiving multiple cases from another hospital, their clinical heads and concerned ophthalmologists have to be informed. Constitute an investigating team that includes the consultant microbiologist, ophthalmologist, operating room nursing staff, the risk managers, and the hospital managers. And they have to look into the operating room environment, pre, peri, and post-operative practices, equipment cleaning and sterilization, equipment maintenance, and case documentation and usage of irrigating fluids. Thank you very much.
Thank you, Dr. Rodney. That was a comprehensive cover of the topic. I shall request you to be here and also answer some questions which I have. Meanwhile, I have an announcement for the audience that we have hands-on, so kindly stay put on your chairs because they will be distributed in a short time, hands-on of all the presentations. So, Dr. Rodney, sir, I would like to ask you, what about the culture negative zone? Like many a times we get that no culture is coming out of repeated samples. So what is the empirical treatment for it, how we should go about it? That's what general ophthalmologists would like to know.
The
So
culture
a take-home
positivity,
message.
the rates of culture positivity are quite high, but even then you get about 30 to 40% cases of culture negativity. So then you have to bring your clinical acumen into place, and then depending on the clinical response to your broad spectrum antibiotics, then you decide on further course of treatment, or in such cases you can also consider doing an early core vitrectomy, a full core vitrectomy, and injecting a silicone oil inside the vitreous cavity, which again acts like a bacteriostatic agent.
Okay, so what are the antibiotics specifically? If you already showed some Vanco and Cefta, so topical and systemic, how?
Yeah, Vanco and Cefta will be the intravitreal choice, and following that, you can, if it is resistant, you can then consider the other rarer antibiotics like ticagrelin, carbapenems, imipenems, and rarely colistin also can be given.
Topically, we should start with?
Topically, again, Vanco Cefta, and you can continue topical of colistin or the other rarer antibiotics, which are more effective in the multi-drug resistant organism cases.
Okay, so Dr. Rodney sir tells that it is a broad spectrum antibiotics topical, fortified if possible, and steroids on low dose for bacterial. Okay, so if the audience is having any question for the first speaker, they can shoot it. Yeah, sir, please, Mike. Yeah, you can just shoot, sir. We can hear you out. Mic idhar hai.
For culture negative endophthalmitis, this means that we should go for early core vitrectomy. So, for how many cultures we should declare it that it is culture negative? So, take just one culture or repeat culture?
If it's done in the proper manner, you can go with one culture.
Just one, only
Yeah,
one
because
culture.
already you are injecting an antibiotic. When you're taking the first culture, you are taking an antibiotic in the vitreous cavity. So thereafter, culturing, it's not going to be of much benefit.
So, any more?
Want to add
Yeah.
on to that, sometimes you might end up getting a dry tap.
Mic, sir, mic. Yeah.
Sometimes you might end up getting a dry tap. So because you might get into a vacuole in the vitreous and you might be getting a dry tap. So that may be the reason why you also might be getting a negative culture. So if you do get a dry tap, there's no harm in trying to repeat the tap just to see if you get any fluid.
Okay, thank you. So next is Dr. Revati Rajaraman. Dr. Revati Rajaraman is the Chief of Cornea Services at Arvind Eye Hospital, Coimbatore. She's a part of the HICC team at AEH. Her talk is on Incident Investigation Committee. So after CE cluster endophthalmitis, first we do is diagnosis, then management, and then comes a role of Incident Investigation Committee. Dr. Revati, please. So, yeah, Dr. Kalpana,
Yeah,
madam,
thank
we
you.
have Dr. Kalpana, madam here. I shall request madam to join us on the dais.
Thank you, Dr. Lipi, for putting up this very interesting topic, actually, as you said, not touched by many people. And my topic is to discuss about the role of Incident Investigating Committee. Especially in a case of cluster endophthalmitis, this is a very important thing. It's not only that we are going to treat these cases, we have to find out the reason and we have to stop the further calamity also. So the fact-finding committee can be either, should be internal as well as external. The internal committee will be usually the hospital infection control committee, and the external committee, of course, the internal committee should inform the governmental authorities, and then they will form the external committees. Usually it will be done by DBCS with a JD, microbiologist, and an ophthalmologist, outside ophthalmologist, and a drug inspector. And also there may be some police inquiry, human right committees and medias, everybody, of course, they are going to analyze everything. But the internal committee, if the role of the internal committee, it should start immediately, and we have to start with a very open mind, and we have to go for a methodical evaluation to find out the possible cause. If we have done it first properly, the external committee's role will be easier, not only easier, that it will be also in a better position to defend ourselves. So this, the committee should first shut down the OT, and also list the possible sources and check for them, and also look and revise your existing protocols, and if there is any violation in that, or if there is any lacuna in the protocol, that has to be revised. And then, of course, trace the other patients. That is also very important. Should be done as soon as you shut down the OT. So to do this, where all the possible infection can come from? Of course, from everything, whatever we use, consumables, or even the personnel, from the environment, from the other things we used in the OT, or even the preoperative preparation area, everywhere we have to be careful. We have to look for everything. So to do this, a proper documentation is very important. It should be like a regular habit for us to document everything. So we'll start with either from the patient list of every theatre, especially the theatres in which these things happen, and the other theatres also. So we have to check the patient list, in what order they have been operated, and in which table they have been operated, and that can lead on to a particular either group of personnel or a group of things what we have used it there. And also as a routine in the theatre, we have to what we are going to use in that particular theatre. All the consumables, the sterilization has to be checked, both physically as well as the sterilization markers, and they have to be documented on a record. So that again have to be revised. And this same thing will be replicated on the patient's case sheet also. That also has to be matched, and we have to find out. So this is very important, the OT log checking. And all the consumables, generally pre-packed consumables, before releasing them to use, we have to take a random sample from each batch, and we have to check microbiologically. Only if it becomes negative, we are going to release it. Even after releasing, after taking this check, after using, we have to keep all these consumables at least for 48 to 72 hours, we have to keep them. And if there is an immediate cluster infection or something, the samples should be taken from these retained whatever remaining material, we have to again recheck. And not only that, again we have to reopen another unopened thing from the same batch, and again we have to check. And all the shared consumables especially, we have to be very wary of, and we have to check, starting from the topical anti-anesthetic agent we are using. From that we have to check everything. And the protocol logs are very important, because even if the fact-finding committee is going to investigate, we are investigating after an incident happened. So if those things have been documented only, we can investigate and find out something. So as a routine habit, all the sterilization logs have to be like in each cycle, how many bins went in, and these bins went to which theatre, and whether the markers are properly changed in color, and the chemical markers, and also biological markers. Of course, we have to do this depends on the load, each theatre. Like sometimes some people will do it once in a week, or twice a week, or even frequently we have to do this, and it has to be documented, and again we have to revisit and check. And also we have to check our fumigation protocols, and calibrating the instruments, the environmental maintenance, all these things, whether it has been done and really done and documented, and is there any breach in this, we have to recheck. And of course we have to take culture from every possible material inside and the outside the theatre, the pre-op area, starting from the tables and microscope and AC filters, even the water source have to be checked, and these things also we have to recheck again. And whether they are done in the methodical way, and we have to check those logs also. And regarding the medicines, everything, starting from even your antiseptic, what we are using before surgery to prepare, that has to be checked. And I'll tell you in a moment, why these things are very important, and their expiry and sample test again we have to do. And I'll share 2 case studies. The first one is a large cluster. It's a infection occurred late, like a month later, a gradual appearing as only inflammation initially, and then found out to be infective. It occurred to a private practitioner in Madurai, and once he recognized that, he couldn't find out the proper reason, because the cases were trickling in one by one, cases which have been operated a month ago. But soon he found out a pattern that one by one these patients are coming. Immediately he sought for institutions' helps, and the institution committees helped him, and then they found out that the offending organism is a rare gram-negative organism, which is actually the source was from the topical anesthetic drop. So the that batch drop, when he used for that 1 week period or 2 weeks period, the patients who were operated at that time, they were coming after 1 month with low-grade endophthalmitis kind of thing, and one by one they were trickling. Unless the surgeon was alert and found out this is a cluster, it could have been easily missed out. And immediately he took steps also to send the patients, refer the patients everywhere, and found out the reason also, and he informed the AIOS committee also, and proper warning also has been given against this particular batch of medicine. That major calamity was avoided because of this methodical approach. The second one, the surgeon used a facility from other hospital because of some need. He couldn't use his own thing, and he went and operated in a new environment where he doesn't have any control. And there, after that, the next day itself, all 4 patients and another surgeon's patients also, they showed signs of inflammation initially. And they tried, even then they recognized it as endophthalmitis and tried to manage in the usual way. The cultures became negative, so the usual routine medications what Dr. Rodney mentioned, they have been given, but then they started showing signs of cloudy cornea, ring infiltrate. They had doubt and referred to our institute. Initially, even we never expected that the offending organism could be acanthamoeba. The accidental, because we did a confocal also, we found out that it is teamed with acanthamoeba, the cornea, then AC tab, vitreous tab, PCR, everything showed acanthamoeba, which is a rare incident, that too as a cluster. So, but here the problem is that it has been recognized after several weeks, and by the time, and that too in a new setup, we couldn't find out the proper reason, what is the source of this infection, still we couldn't find out. So sometimes immediate action and also a proper follow-up only, we can find out the proper source also. So in conclusion, this is a nightmare situation. Of course, it has been rated again. Like we have to be defensive, but we should not deny or ignore or argue with the condition. A calm and methodical approach, face it and explain to the patient and methodically approach. And the internal committee should be strong, internal documentation should be very strong, so that we can find out the reason, so that we can be in a better way prepared to face the external enquiries also. We can avoid very bad situations. And also very important to recall all the patients operated during the time and make sure that whether they are involved, they are affected or not. That is also very important. Thank you.
Thank you, Dr. Revati Madam. Incident Investigation Committee, we all know it has got a great role to play after CE. So investigation committee, as I have seen, is quite stringent actually with protocols and log check. Apart from entries in registers and computers, they check all that, and then they check on surgeon's nail is fully trimmed or not. They take oral statement from OT staff regarding the surgeon, whether she or he carries her mobile, purses in OT room, wears slipper, mask or cap properly or not, dons gloves properly or not, all is probed into. So surgeon is actually taken to be a murderer. That's my personal experience. Okay, we also have with us, we are fortunate to have our HICC team head, Dr. Ram Mohan, Arvind Eye Hospital, Coimbatore. He is HICC team head. So any questions from the audience for Dr. Revati Madam and Dr. Ram Mohan about this incident investigation team? Okay, so we move on to the next talk, that is Dr. Kalpana Narendran, who is whole and soul of AHCBE, OT chief, cataract and IOL service head. She is here to deliver her talk on the OT essentials. So the prerequisites for an ophthalmic OT.
Thank you for the opportunity to be here and also including me in the instruction course. I'll be talking about regulatory requirements of ophthalmic operation theatres. As surgeons, we all know that the most dreadful complication in a post any ophthalmic surgery would be endophthalmitis or the TAS, the toxic anterior segment syndrome. So it's very important to have a proper environment while we are operating, because one of the high risk areas is the operation theatre. Somewhere I read that the operation theatre is considered the heart of the hospital. But I always, when I talk to my nurses, I say the sanctum sanctorium. When you go to the temple, the most sacred place in the temple is that. So you have to give that respect to the operation theatre. I always tell them at all times, because what happens in the morning when everybody is around and the theatre is on, everything is maintained. But then in the evening when you go, the whole place is chaos. Everything is dropped down. So it's always better to maintain the theatre in the same status, whether it is morning, evening, or any time of the day. That is why I said sanctum sanctorium. So, the regulations for operation theatre, one way we are, lucky and glad that the government has given this National Building Code. There are 2 volumes on this. So it's very important to follow the regulatory protocols, which is advised by the government. And now a lot of stringent actions have been taken on that. The fire safety has to be taken into account for the safety of the workers of the hospital and also the patients. And you have to be very selective upon the building material, the products you use in the OT and all that have to be kept in mind. And the National Program of Control of Blindness also has a role in what is to be done in the ophthalmic OT. And with the recent National Accreditation Board for Hospitals, they have a separate accreditation standard for eye care organization, which gives a detailed protocols for what is to be used in the operation theater and what are the validation methods which you can use to test if your processes are correct. And the important requirements in the OT would be the designing of OT, very important, and then the heating, ventilation and air conditioning system, and the other disinfection protocols which you use for the sterilization of instrument for the OT environment, and more importantly the periodic validation, which I will be talking about in my further slides. And first of all, the very important thing is position of OT, because initially the positioning of OT was not paid much attention. Like in the hospital where I work, which was built 23 years ago, we have the OT in the first floor where so much of patient movement is there. So now we are coming up with the new block, and all the other new facilities of Aravind Eye Care system, the OT is on the 5th floor where the least patient load is there. So that is very important to position the OT in a particular place. This was interesting. This was an oil painting which was called the Agnew Clinic 1889 by Thomas Eakins. This was mainly to honor David Agnew, who was an anatomist working in the University of Pennsylvania. This is just to depict how the theater used to be there in olden days. I think that is why it was called as a theater, I think, because people were sitting around and watching the surgery. And but now the zoning of OT is another new thing which has come up. So you need to zone the OT into protective zone, clean zone, aseptic zone and disposable zone. This is mainly to prevent the bacterial contamination and also to maintain different pressure gradients in the different zones. So this is the layout. Do you have a pointer here? Okay. So if you can see that in the zone 1, you will have the protective zone will have the unsterile, the reception, the changing area, thank you, the changing area, the record maintenance and all that. And then coming to the second zone, the semi-sterile zone, you will have the change room, the transfer zone, and then the sterile will have the scrubbing, gowning, blogging, the autoclave room and all that, and also the surgery operating rooms will be in the sterile zone. And the disposal zone will be the equipment and supplies. And more importantly, this is what is important. You have to follow the unidirectional flow. You can mark this green and the red. So this is very important to maintain this corridor to prevent infection. And coming to the next most important thing is the heating, ventilation, because the quality of air is very important, because another important factor for causing infection is the quality of air. So you have to have dedicated air handling units, ducts, air conditioned compressors, and this AHU should run 24 hours with variable frequency. And then you have to have devices to conserve energy, and then you have to have 2 pre-HEPA filters which are 5 and 3 micron sizes, and then you have to have the laminar airflow and the 0.3 HEPA filter. Again, these HEPA filters have made a revolution, because olden theaters we used to have the system of formalization, fumigation, but these theaters which is HEPA filter, you don't need to do any fumigation. So these are the requirements. I'm not going to the details. These are the requirements of the air changes, the velocity and the positive pressure which has to be maintained, and the temperature and humidity is also another factor which you have to keep in mind. So all the theaters should have a temperature monitoring system, so that you see how much of humidity and temperature is there and make sure it is maintained. And this is just a video to show you the how the airflow should be there in the OT. So the HEPA filter system. So you have to have the efficient particulate air systems, which almost brings 99.97, about a 0.3 microns. So it removes most of the microns, ranging in size from 0.5 microns. So it's very important to have these kind of systems. And this is not good for operation theaters. You can go in for a split air condition if you do not have a facility to have a HEPA system. And inside the operation theater, this is very important. You have to have this hermetically sealed doors, preferably stainless steel if you have access, the stainless steel roofing, and then the flooring has to be in a particular way, and this kind of a coving is very good for cleaning, and also it prevents deposition of bacteria and prevents contamination. And there are also other areas of high risk surveillance, like you have to keep in mind about the hospital acquired infections. Needle stick injuries have to be kept in mind. It is very important to sensitize your staff and the other other workers in the hospital about all this and make sure that proper action is taken against the needle stick injuries and other hospital acquired infections. Because the source of infection could be any of this, because so many people are handling and then so many instruments, especially when you have an overloaded operation theater, there are so many sources of infection. So you should keep that in mind and try to take action to avoid infection. And always better to create an environment which is free of living microorganisms, including spores. So you have to have a proper cleaning of the operation theater. So microbiological surveillance should be done. The OT should be cleaned with solutions which are recommended, and then also the walls should be cleaned with wet mops, and that is very important to also check for sampling the growth of microorganisms with different you have to check the air quality. You can do the settle plate technique, and you can take swabs from the theater, which will give an indication if there's any contamination. Coming to sterilization proper, the autoclaves which are used for sterilization, the vertical autoclave is not good because it doesn't really maintain the pressure gradient, but the horizontal is a very good one. Flash autoclaves can be used, but it is not really recommended in ophthalmology, but for dropped instruments, they say you can use a flash autoclave. And this is just an indication. The double door autoclaves are very good now. They have their own printers and indicators, which will give you the cycle time, set pulses. It's a lot more easy for you to, even during the process, you will know what is the cycle time, so which will help you to get better sterilization done. So this is just a documentation sheet which Dr. Revati already showed you. This is the CSST team, their documentation. This is our senior CSST team in charge. So you can see the documentation of all the process of sterilization. And this is very important to maintain these records. And the chemical indicators, you have 6 chemical indicators. The class 5 and 6 are the most crucial one, because if you use this and this helps to to show you if you have achieved all the critical parameters. And again, the TST is very important to see how much temperature, steam and time. So this is also another indicator. And again, the monitoring record. So this just showing you what we follow at our hospital. So this is the monitoring record which shows the color change. And the most important test, the Biomedical test, which is mainly to test the vacuum levels in an empty load sterilizer. This helps you to get the sterility assurance level. And this probability, the probability of this test is 1 in a million spores survive the process, because we know that the bugs don't lie. So you use the biological indicators. This is double, it has got 2 chambers, inner and outer chamber. The inner chamber will have broth, and the outer chamber will have the thermoresistant thermophilus. So if the color changes to violet, then if the color remains violet, then there is no problem. But if the color changes to yellow, it means that it is not, there's some kind of infection. So again, this is just to show the, why I'm showing all these, these charts is just to show you how strictly we maintain these protocols. So this is just to show the different autoclaves A, B, C, D, and then the result. And the incubation period is 48 hours, but then now I hear that there are some rapid readers where you can get results within 2 to 3 hours. And coming to the instruments, these are the sets which are autoclaved in between surgery. So we also have indicators whether the sterilization is done properly. And again, sterilization of instruments is very important. You have to use the ultrasonic cleaner can be used with the proper cleaning of the ultrasonic cleaner itself. And then very importantly, the main, one of the main culprits for causing TARS would be these enzymatic detergents. So it's very important to clean them, your phaco handpiece, your tubings, and then ethylene oxide sterilization also has a role. So certain instruments and equipments which cannot be steam autoclaved, so you should also use the E2O. And fluids which are used in the operation theater could be another culprit. So whenever we open a new batch of fluids, so we always take one sample from the batch, and then it is you tend to find out if there's any growth in the organism. So this is again kept in kept in record. So it's very important, any BSS or a ringer lactate or any viscoelastic which you use, sampling is done. And again, like Dr. Revati mentioned, what batch is used and which is used is always mentioned in the case sheet. This will be helpful when you get an untoward incident. To review the records will give you an idea. So again, the doctor also gets to know. So every day when the doctor comes into the OR, the practice which we have in our hospital, we have to sign this. You can see Dr. Gopinath, Dr. Shalini, so this we sign it, so we know that this is being done. This is like a double check. Even if the CSST team does it, the doctor who comes to theatre also checks it. So once you know that there is a contamination, then you recall, don't take any efforts, just recall. And also we have a habit of informing the company before that there is a problem in this batch so that they will be alert. So again, I was talking about the sampling in the different theatre areas. So this is just to show you the, from front, back, floor, air conditioned wall. So this is taken and then we monitor. This is usually done once a week. Sometimes it can be done twice a week if the load is more. And most importantly, the other important thing which we use in the OR is the water. So you need to have a reverse osmosis plant and make sure the water quality is good. And then hand wash is very important. Again, hand washing complaints, audit has to be done to make sure, because not everybody follows the protocol. So it's another important step in the operation theatre to prevent infection. And most importantly, and the last would be the biomedical waste management. So because we know that 15% of the infected waste can become 100%, it is just very important to sensitize all the people in the OR and the housekeeping, the medical, paramedical, the patients and the public and environment to proper biomedical waste management. And preferably the segregation should be done at the source, which is very important. And because if you don't do it at the source, you will be spreading infection. They'll take the whole thing elsewhere and then it will be contaminated. So, and you store it for only to about 48 hours. And the fluid we use normally, like Revati mentioned, we keep it for 48 hours in case any untoward incident happens. So all this safety requirement, if you follow, you definitely can aim at a 0% incident of post-operative endophthalmitis. And we at our institute, our point was initially like 0.07, now we've come to 0.01. So because I take care of the operation theatre, I know very well if you're very stringent, if you validate all your results, even sometimes dreams can become reality like this. And I want to end by saying that Florence Nightingale said that it may seem a strange principle to enunciate that the very first requirement in a hospital is that it should do the sick no harm. So most of the infections could be iatrogenic, so one should take all the precautions, because eye is a very small structure, so anything harmful can, the results can be devastating. So we should all work together to, to bring an environment which is safe and, protective for the patients. Thank you.
Thank you, madam. The records shown were practically useful to us. I will invite Dr. Anandesh Pandey for his next talk. And meanwhile, while sir gets ready, I shall like to know from Dr. Kalpana, madam, some practical points. One is about scrubbing. So scrubbing, should it be done after every case? That in between the cases, after every case?
Ideally, it should be done after every case. That is what the American Academy, all the guidelines give. But sometimes in a high volume theatre like us, we may not be able to do it for every case, but we do it every hour.
Every hour.
Every
right.
hour we scrub the theatre, yes.
Right. So basically, if the surgeon has taken the morning bath, then he may not scrub after every case. Okay, right. Okay, and another point which
You're asking about scrubbing the theatre or the surgeon?
The surgeon.
Oh, I'm sorry, I was thinking theatre. The surgeon, we don't do after every case, but then the recommendation is after every case, and you have to deglove, came everything, but some institutes do that. We change the gloves, yes, we change the gloves for every case, but we don't scrub.
For every case, madam?
Yes, for every case.
So any more audience questions for madam? We have a panel discussion while you think over the questions. Another question which I had in mind is that use of phaco tip, like phaco tip, it should be changed after every case. How practical is it? Should it be done or not? Recommendations are many actually, so we cannot have a 5-star OT.
Yeah, the phaco tip ideal recommendation by the company is single use. But it is not practical with the expense. You can't use it single, so you can use it. I mean, some companies you can for 10-15 cases, but you can even use up to 100 cases. But then use one phaco tip for every case. You can autoclave it and reuse it again.
Okay, for the next case, right.
Yeah, for every case a new one.
Yeah, sure. Mike for the...
Until now, still now, I think, the blame for endophthalmitis, I always used to point my finger to the surgeon. He's the one who let in the box. No matter now it has come to 2.2, 2.8, but still if the surgeon who is at the box end, having listened to you, it's not the surgeon only, so many factors, protocol, still do you believe in what I say, that the blame, if you want to point someone, is the surgeon?
No, sir, I think the surgeon has to take a major role, because what happens a lot of times, the surgeon does not pay attention. They take everything for granted. So, you know, it's the surgeon's role to take responsibility. I've seen surgeons who operate don't take notice of what is happening around. But I think he has to take that's what I'm saying. The surgeon definitely has a role because he is responsible. So, you know, when you are responsible, you have to take all the efforts to see everything around you is right. So, in a way, it's the surgeon also has to take a, you know, major role, because he'll be the one who will be called and
Can you add that? I am speaking on that subject only, what you are telling now. We have up till now heard about how to prevent, what to do after the infection is there. And in good institutes like Arvind, you can have a samples and do those things. But in general, where everybody is practicing and getting 1 or 2 or anything, that is the main problem of the cluster infection and the legality coming out of all these infections. And I am dealing with that, which just now you said, who is the responsible. So, the legal aspects of cluster infection outbreak in ophthalmologic surgery may happen in a solo practice or in a trust or corporate hospitals. Because it can happen in the solo practice also. If there are 3, 4, 5 operations, somebody is doing that, and there can be a cluster infection. And the legal liabilities are different in solo practice and trust or corporate hospital. Because what she was telling, that surgeon is definitely responsible. But yes, in solo practice, he is definitely responsible. But in trust or corporate, the responsibility is divided or taken over by the trust and hospital, because there is a Supreme Court and National Forum decisions on that. So, under Consumer Protection Act, civil liability for negligence in solo practice, it is his responsibility as he is the owner of the hospital. So, whenever a small hospital is there, he is the owner and he is looking after, so wholly he is responsible. In corporate, trust or government hospital, it is the hospital responsibility, as the Supreme Court in their verdict, their own words are these. The patients, once they are admitted to such hospitals, it is the responsibility to satisfy that all possible care was taken and no negligence was involved in attending the patient. These are the words of the Supreme Court. In fact, it is the hospital who engages the treating doctor. Therefore, it is their responsibility. I mean, that is the hospital's responsibility. Another, therefore, no individual doctor is liable and can be held jointly or severely liable. Severely means along with. This is a legal terminology. So, cannot be made liable along with the hospital also. Even visiting doctors or consulting doctors in private hospitals cannot be held liable, as the consumer patient, that is, patient is a consumer because he is paying the money, and the hospital or the doctor, whosoever is receiving, is the service provider, does not avail services of such a doctor individually by paying fees or consideration to these doctors directly. So, in all hospitals, it may be a trust hospital, it may be a corporate hospital, or it may be run by somebody and somebody is coming there and doing the work. The hospital receives the money from the patient. So, patient is paying to the hospital. So, the consumer is the patient, hospital is the service provider. So, doctor is in triangle and doctor is giving his services to the hospital. So, hospital is consumer of the doctor. So, this is a triangle, and this, because of that triangle, the Supreme Court has given this decision. Whenever cluster infection episode happens, we have seen so many discussions, cluster infection happens, so it is being treated and everything. The doctor is blamed. Is it correct what you are saying? Doctor always, whenever you can see the incidence of Indore hospital, because I have just now visited and done all the things of the Indore hospital itself. And because the cluster infection cannot take place because of surgery, as the subsequent surgery cannot meet the same complication even if one had in the first surgery. So always there cannot be same complication, or there cannot be same thing which will cause the infection. So surgeon cannot be blamed. One complication surgeon may do, drop nucleus may happen, posterior capsule may rupture, but in second, sir, no. If the second is also infected, where the surgeon's role is there. But the cluster infection is because of infection source beyond the control of the surgeon. In solo, it is in his control, but in hospitals, trust, corporate or big hospitals, it is beyond his control. And for that, surgeon cannot be blamed, and immediate action should not be taken against the surgeon. This is the role of the medico-legal here, and we are fighting for that from the along with the AIOS. Means AIOS is fighting, and I am in between of the fighter. What are the sources of cluster infection? That is hospital source. I have not to tell much because so many speakers has said. But what I want to say is that material source, which is that Arvinda Hospital, whenever there is a batch is changed, they take the sample, they treat in pathology, see in the pathology whether there is infection. Is it possible for everybody? For even a trust hospital there in other cities where all these facilities are not available, is it possible? No. And so they have to believe what is said as a sterile, they have to use that sterile. And if something happens, doctor is blamed, hospital is blamed. So disposables, pre-sterile materials supplied by the supplier company as visco, irrigation fluids, etc. Surgeon is not responsible for the sterility of such material. Then why surgeon is blamed when he is doing the work with social work attitude and without his any fault? So this why he is not at all fault, but the media, the people all blame the surgeon and say the doctor has done the butchery. Why? Why they should be say that the doctor has done the butchery? Afterwards it is revealed that viscous was infected, and so it has caused. After it is said that gloves were infected, and sometimes the irrigation fluids, and so many things are. Even I have a lens which is having a fungus on that, and it was labeled as sterile, and as doctor was introducing it, he stopped and he seen with the fungus there. So this can happen with anybody, in any institute, in solo practice also, then where he is responsible. So what role AIOS state and local ophthalmology society should take in such circumstances? The surgeon as an individual is not sufficient to face the circumstances. So AIOS, state or local ophthalmic society should stand behind him as he is if he is not at fault. And in cluster infection, he is not at fault if the source is not of the hospital in solo practice. A task force committee of AIOS, state or local ophthalmic societies should rush to the place which will have legal members to see the legal matters and to take legal steps to protect him from unnecessary harassment which happens without finding the real facts. So one individual is not sufficient when there is a cluster infection. And the doctor, once it happens, is blamed by everybody and he cannot face all this. In such circumstances, our societies should stand behind and find out, treat the patient definitely, and take the patients from the infection outside. That is also a part of it, but see that he is not morally depressed. As happens many times that the surgeon is proved to be not responsible for it, and sterile material supplied by companies were at fault. And most of the places where cluster infection happens, it is found there only. In few hospital source may be there. Cluster infection, for example, just now as I am speaking from the body of a AIOS as a legal chairman of the legal committee. The cluster infection episode of Indore Eye Hospital, we can say here that doctor and hospital were blamed. Media also contributed. Registration of the hospital was cancelled and hospital was sealed. All these things were done after the cluster infection. You have seen in media how they were speaking about the doctors and hospitals. But afterwards, AIOS stood behind the hospital as AIOS task force. I represented the AIOS and visited Indore, represented in the High Court and proved that doctor and hospital was not at fault. And so the hospital registration was reinstated and seal was removed and hospital was restarted. No blame was given to the doctor. But when it happened long after the defamation of the doctors and defamation of the hospital has happened. So this should not happen, and for that we are fighting from the AIOS that we are going to put a public interest litigation in the Supreme Court that such things should not happen. If the doctor is fault really after the inquiry, definitely punish him. But if he is not at fault, hospital is not at fault, they should not be defamed, they should not be punished, and for that we are fighting that, and the suggestions are should put a public interest litigation in the Supreme Court to plead that. And for that, yesterday I was with the advocate of the Supreme Court and discussing how it can be put. And then I understood that there are lacking so many things. We are not having the documentation at present with me, at least, which will support our public interest litigation. So I request all AIOS members and all bodies to support this and send the documentations wherever the such infections has happened or wherever it is found that the sterile material supplied by the company was found to be as a infected material. So Arvind Hospital may help me a lot because they are testing each batch. So whenever they find that there is infection, send that documentation to me of this batch was infected and the previous batch was not infected. And we want to prove that only we are fighting that every batch of the drug, such used material, should be checked by the government organization and should be certified that this is a sterile, and when it is sterile and marketed, the doctor should be very safe and confident that I am not going to get the infection from that. Whenever it is found that the sterile material supplied by the companies is found infected, the manufacturing company should be prosecuted for the damages to the patient. But it doesn't happen because they are having so many strains, people, money, people, approaches and all that, and nothing happens with the manufacturing companies. The Honorable Court should give directive principles that the surgeon should not be prosecuted unless and until found guilty. Should give directives to the Food and Drug Department that they should lay down a system to prevent such infected material to come in the market to save eyes of the patients. So what is happening? Everything we are seeing, we are blamed, not blamed, whatever happens. But the sufferer is who? The poor person, patient. He may be poor, he may be rich, even he may be the president of the India also. He can meet the infection because through of the company. So what they should, what is there is a provision that they will not get? What is the criteria that a doctor is safe to use the material? And for that we are fighting. Government should lay down a system by which all batches of the such sterile material should be certified separately as sterile, and doctor, hospital should purchase only such material. So hospitals and doctor will be safe from one point at least. Hospital infection is different. That is their management responsibility.
Thank you, Dr. Anand sir. He's a very resourceful person. I think you should note down his number and email address so that we can approach him in our hour of need. Well,
Supreme, yes, thank you. One thing the Supreme Court has given the decision that for everything doctor should not be blamed, and there is that The Supreme Court, in case of Gupta, he has said that every for thing. Doctor and hospital both are have mishap or death during medical treatment. The medical man cannot be proceeded against for punishment. Thank you very much.
Well, thank you, sir. I'll be just quickly rushing over my topic in 3 minutes maybe. So this is something akin to what Dr. Deshpande sir was telling us, that medic is not always to be blamed. I also believe on this, because sometimes he's under a government, he's working under someone. He's not the only person who is responsible for everything, every workup which is taking place in the OPD and OT. So the medic and the mass media, the melodrama which ensues. The irony is that after cluster endophthalmitis, the surgeon needs to produce self-evidence that he or she is not guilty. And after murder, the victim, family or friends, they need to produce evidence that the murderer is guilty. So you just note the difference. And this pronouncement reflects on the surgeon's and the murderer's attitude. Is this right? Keep calm, take a break, matter will take care of themselves. This does not happen. I will say keep calm, but you need to take charge. To handle mass, you need to take charge to handle mass, the public and the patients. For this, the surgeon needs to communicate to the department and hospital authorities if he's working with someone, under someone. Next, he needs to show compassion and concern for the patient. This is of course natural, but this is a wild period. You'll be getting all wild questions. You need to be patient, be polite, be wise, and consult wise men, not all men. Don't waste time, just consult the wise men. Be tactfully truthful, be confident. Then next, how to face the media. For the surgeon, communication. Communication is communicate to the department and hospital authorities. If they are with you, if the hospital spokesperson is mature enough, experienced enough, then your burden is lessened. He'll handle the media. Attitude, avoid controversial statements, maintain a balanced attitude, and the action is discussed with ophthalmic state and national societies. This should be done early on. I believe this. As Dr. Anant has told already, AIOS is with us. State societies are mostly with the surgeon. Press release, paid news, and legal action, this all happens. Paid news is there, both positive and negative paid news. I have experienced that myself. It depends on you whether you want to go for it or not. Legal action, it depends whether you want to take it. It's worth vesting or giving your time, effort, and energy to what your future will be after this legal action. For the hospital and the department, what should be their attitude towards media? First is communication, understanding, empathy, neutrality. That should be done to the surgeon, and they should take responsibility. So they should not just shrug it away. Everything to the surgeon should not be blamed on that he was a person who is responsible. They should take some responsibility. Offer information to the media rather than just finger on lips and hand on your mouth, and when that hand goes to mouth and the nose and the surgeon is stifled, we never come to know. So rather than keeping mum, it is always better to offer some basic information to the media. There are some news items, I won't go into detail. I have taken the past ones, not the recent ones, for obvious reasons. So this Motiabind Kand, this word is very interesting. I don't know from where this word has come, and I would like this to be taken out from the Hindi dictionary. I would like ophthalmologists to go for it. So if the department, the hospital, and the surgeon is not going to the media, the patients, they always go to the media, and you get all such absurd reports. अस्पताल प्रशासन हमसे लिखवा कर ले रहा है कि हमने मर्जी से छुट्टी ली है, and all those who know Hindi, they can read it. Such images, such pics are put, they are taken from other source and they are put into the news item. It reflects as if the same surgeon is doing the surgery in the same sitting. It is not so. I appreciated this article, a recent article 2018, which stated that the expert team which is investigating a case of cluster endophthalmitis is actually not that expert. It also needs recommendations, and the final conclusion was that post-operative endophthalmitis is a multifactorial event. So we need to just accept that there is going to be a whole lot of melodrama after CE. What you need to do, you deal with the mass and media and then just accept. And crying is not allowed. That's a crap. You just cry, get over with it. Think on the positives, think on the experience you're going to get. You may get an IC on a national platform. You may give some presentations, write article to the editor, revelations, who are your true friends. You come to know re-evaluations on self, what practically and surgically you were doing wrong. This is the request which I would like to do from this podium. Just mark that hand. So support to the person and organization, to the ophthalmologist, that needs to be given who is facing the cluster infection. We all ophthalmologists should come on the same platform and try to do this to our colleagues, junior or senior. Endophthalmitis, as we all know, as already said by me, it is not an end for the eye, for the surgeon, and for the hospital. This is my email ID and WhatsApp. I have personally gone through this experience. Those who want to know firsthand, there are many things which cannot be openly shared on this platform. They can contact me, and this is mainly for the handouts, because I could see some sorry faces when those handouts were distributed. The number was limited, and many have not got it. So you can always WhatsApp or email me for the PDF copy. So any quick questions? All the speakers are here. Any quick questions from the audience? Okay, thank you. So I think I wrap up this session. We are bang on time. It's 10:25. Thank you all. I thank my co-instructors for participating. Thank you.